Vinaka. You're here on Straight Talk with Vijay Narayan. And today we have a very special guest, Permanent Secretary for Health, Dr. James Fong. We have been trying to get hold of him, a very busy man, for you to hear from him what's the situation at the moment. The country gets a chance for him to have a candid conversation on what is happening on the ground. How are we seeing things as far as the country is concerned? So first of all, Dr. Fong, thank you so much, Vinavalevu Bodhanavad, for coming on the show on Straight Talk to talk to our people directly. On behalf of our listeners and users, everyone, we'd like to thank you.
Thank you, Vijay.
Dr. Fong, good to see you back in the office after your quarantine period. The tests all confirmed negative. I believe the last one came at the end of last week.
End of last week, the 12th day one. And yes, we are glad to be back. Well, we are glad to be back with on our feet again, trying to move forward with what everybody can see is escalating around the Central Division. Yes, and we're hoping that with our ability to move around a bit more, we can get a better sense of some of the small nuances in the response plan that needs to be sorted.
So, Dr. Fong, how many COVID cases we have at the moment? How many COVID cases have we had so far? And how many are severe cases?
So, right now, the total number of active cases is 1,542. We recorded, there were quite a lot of recoveries overnight, about 59 recoveries over the last 24 hours, of which 17 was last night. When you come to severe cases, I mean, all our severe cases are in CWM. And currently in CWM, we got about 60 positive persons in CWM, out of which 11 are what we call what we call severe. They require oxygen. Not all of them are actually. They include those who are suffering from COVID-19 and those who are suffering from other diseases. So at the moment, sometimes to some extent, it can be quite difficult to tell the difference between who's a severe disease of COVID and who is severe disease of other illnesses. But every one of these severe ones are having significant comorbidities, significant other illnesses. One of the patients had leptospirosis and had passed away overnight, unfortunately. And the team is just looking through the evidence, clinical evidence, to work out again whether it is a COVID death or not a COVID death.
Now, how are the health workers and other frontliners doing during these very trying and challenging times? How are the frontliners coping, knowing that they also have to push long hours away from home?
I think what the frontliners are now going through is exactly the same thing that has been happening that we've seen all over the world. The frontliners are having to cope with a lot of criticism. There is, if you take the frontliners out in the field, yes, they are struggling because many people are quite perplexed when they have to be isolated. I do know that many of our isolation protocols has evolved over time, so that we are now strengthening a lot of our community isolation protocols. We do have challenges with some of our community isolation protocols, especially the ones that we have to institute in crowded neighborhoods. We've tried to move a lot of them out of their living facilities and into facilities that we have set up. Unfortunately, that exercise is never easy, because a lot of them feel that they need to maintain their house to be secure. So we have actually now decided that we've moved quite a few out of their facilities, but we've kept at least just one person to guard the house. Somebody who's asymptomatic, positive, asymptomatic, who we can actually oversee and make sure they stay in the house. So, but I must admit that at this point in time, given the rising number of cases, the rapidity with which we're increasing with new cases, moving people out, positive people out of the community and into isolation protocol is becoming a severe challenge. We've had this morning had a big discussion with a number of our other ministries about setting up community isolation facilities. We had initially tried to set up community isolation facilities. However, we had some problems in that some of the community isolation facilities were not seen as up to par. What we are struggling with now is our community isolation facilities. We started off with doing community isolation facilities. We've had a lot of trouble with some of the community isolation facilities. They were not as, we couldn't get that up to standard as we had hoped. We then negotiated with a number of facilities within Suva for us to be able to keep people in. Unfortunately, because the number of medical people were beginning to get affected, we had to start also accommodating medical teams to be working in work bubbles so that they could keep their work bubble as negative for as long as possible. That restricted the amount of isolation facilities that we had, and then therefore we started looking outside. And then as we started looking outside, we were able to get some in Nandi, but there are other facilities that we have struggled with because of some resistance to relocating facilities out in the outside of Suva. We hope to get some resolution to the discussions that are happening in Nandronga with regard to Outrigger. And now we are beginning to re-explore again our original idea of reopening some of our schools to be community isolation facilities again.
I'll touch on facilities, but let's look at facilities and staff at the moment. You've got CWM, you've got Lautoka, Nadi, and some other major health facilities where you've had cases. Of course, as you said, CWM is concerning. FEMAT, you've had 2 cases, I believe, in the sorting area, and you've also got the medical ship running. Can you talk about how you're managing with some of these critical facilities and staff, knowing that you've got active cases?
So one of the objectives that with regards to Lautoka Hospital, we went through a process that you typically do when a hospital facility gets affected. We were able to close it down. And we only were able to close it down because we were able to regenerate facilities around Lautoka Hospital that we could use for the same purpose. Lautoka Hospital also had a case that had been sitting in the hospital for quite a while and got infected and then went through the whole process of getting infected and then finally getting severely sick. So that's usually over a long process. So that was two of the reasons why we had to close Lautoka Hospital down, because we knew that the index case was there for a long time. And it was important, therefore, to separate positives from negatives. We ran tests about 4 or 5 times through the whole group over 21 days, and we were able to work out very clearly who was positive and who was negative. So that was Lautoka Hospital. CWM Hospital is a challenge, because there are services in CWM Hospital that can never be replicated in any other facility effectively. I'm glad that the maternity unit actually came up with a number of protocols that have been able to ensure that they maintain their services. So they've got a sorting area where the clinic was. They've relocated clinics outside of CWM. They've got a sorting area where the clinic was. And patients who are of indeterminate status get managed there. Only patients who are proven negative, they go up to the clean area on top, upstairs, above the antenatal clinic. So using that method, they've been able to actually maintain that CWM functional by having 2 separate areas for the unsorted and for those who have tested negative. Unfortunately, with CWM, because we cannot close off all the services, it has also been a bit of a struggle trying to sort out our negative cases. That we were trying to put all the positive cases in the West Wing, that's in the wing, the old hospital side. And then we tried to put all the negative cases to stay in the East Wing. That's where the operating theaters and most of our other critical infrastructure are. We're finally able to sort that separation now. And we do have a number of ICU capability on both sides of the hospital. So now moving forward, we are we are in a better position now to start facilitating more clear clearance of cases into COVID cases that are sitting on the old hospital side and the non-COVID cases that are sitting in the East Wing, that is towards the operating theater side. Together with the FIMET is providing extra non-COVID bed space. So that means we can get people sorted in our sorting area. If they're testing negative, we can move off to the FIMET tent or to the arena. And then we got the MV Vivueti that's providing surgical services for those that we can figure out are negative. All these changes will have to continue for quite a while, because we believe that even before COVID, we were struggling with bed space in CWM. But we had the freedom of being able to move people out into the subdivisional hospitals. Right now, our subdivisional hospitals are being used as isolation facilities. So one of the contingency plans we had was that once we have filled up all our other spaces that we could fill up with isolation facilities, the next one was to build our field hospital. Our field hospital right now is the one in the arena. And then we've got another space for the field hospital to expand to, but we don't need that at the moment. Beyond that, we have we brought in a number of experts from Australia and New Zealand, together with some of our international colleagues from WHO who are now sitting with us, and they've been going through some of our contingency plans if we have any further worsening of the situation. These groups of people have been with us for quite a while, and based on what we are seeing, they have decided, or we have decided, to start activating that group to come and help us to plan beyond the contingencies that we already have.
Now, the cases continue to rise. What is the increase in the percentage of cases on a daily or weekly basis at the moment?
I think one of the things that we are using is our doubling time, and that's probably the best way of aggregating all of that. It's our doubling time our doubling time at the moment is about 9 days, and that's been fairly stable for quite a while. So if you work out that doubling time and the number of cases that we are gonna go through per day, we are at what I call the escalating phase. We are in the steeply rising part of the phase over here. Now that phase represents only what's happening in the Central and Nosori. At the moment, Central and Nosori division, our number of cases have come down to a more stable or acceptable level, but our biggest concern now is Lami. And that's been one of the biggest, we've been working very hard with the team. One of the reasons we are both late, I'm late in this interview, is because I was down in Gawia village just a few minutes ago, trying to help work with the team on how we're going to sort out some isolation process within that area. We are hoping that we can hold or at least do some containment program within the area so that we can contain the disease in there.
Let's talk about Lami. It is a red zone now, and very concerning. And we have seen that also feedback from the ground, there's very little adherence to COVID-19 protocols. A lot of residents have raised this concern as well from the ground. You have been to Gawia village today to try to sort things out. How much more would it take now? It's getting very serious.
Yes, it is I mean, we've gone through this discussion for quite a while, and many of us have tried to, I know I've gone through a number of programs to enforce COVID-safe behaviors in all our settlements. It's one of the reasons why the medical team have got themselves caught out, is because also a lot of our general cadre of staff, they live in these settlements. So it has affected us in quite a negative way. And in fact, I think there's quite a few of the government places that have had a close shave with COVID has been because of some of the general cadre that live in these crowded settlements. It is a difficult ask to get a lot of these people to look beyond the immediate needs and to comply with our COVID-safe measures. We try to set up educational programs. We've had people going into these settlements, talking to them about COVID-safe measures. When I went today through Ngawia, I noticed that everybody had a mask on. There was everybody had a mask on. There was some were not wearing it that well, some were wearing it well, but people were wearing masks. But I can see that the situation in Ngawia, situation in Waila, and many of our crowded communities, they live so close to each other that it is really fairly difficult to ask to look at 2 meter spacing. And again, this is one of the reasons why we will have to start looking. We have as far as possible moved all our positive cases within these crowded areas out. But getting back to the question you're asking, how do you sort that situation out? I think one of the things that we'll have to do is we'll work with what we can. Like I said, I went to Gawia, most of them were wearing masks. That's a positive. And we got to work with the positives. And now that they got a few cases that are close to them, we are able to go in and have a discussion with a lot of their leaders, or those who lead various parts of Ngawia, to try and get some of their community leaders to be involved with our issues around social gathering. As you can understand, one of the hardest places to police is social gathering. We've tried to enforce restrictions on social gatherings in all of the heavily populated areas. It is a challenge. I've had stories of people will go in to stop one Yangona drinking session in one place. People will pack up their things, they all walk away, and then after, as soon as the police go away, they just move to another place. So there are certain parts of our social habits that are prevalent in all those crowded areas, and it is not going to be a short, this is not going to be a short journey. We are going to have to keep working on them. And like I said, I just went today, I saw a lot of people wearing masks. At least that's a positive.
That is a positive. Unfortunate thing, maybe with rising cases, then they've decided to do that. Now, how many people are now in government quarantine facilities, and how many are in home quarantine? And do we expect more people to be housed in home quarantine going forward?
Yes, the challenges of trying to maintain people in government quarantine facilities is quite significant. We've had close to, I know that there's about, at the moment, I don't have all the figures with me, but I do know that at the moment there's something close to about 284 people that are in isolation as we speak. And these are people on home isolation, and the rest are on facility-based isolation. Sorry, I don't have the actual numbers for the total at the moment. But I believe that the number that you want to work out is how many are in, how many home isolation So you got about 210 in Suva subdivision. There's 72 in Rewa subdivision, and we have 2 in the Naitasiri subdivision. They currently we have selected these places based on the criteria that they are living within quarters or within spaces that are easy to maintain. It has to be fairly far away from neighbors, and it needs to be somewhere that we can provide good oversight over in terms of security. Yeah? And there's a protocol that is given, plus they are given a piece of paper that they sign off to say that they will abide by the requirements of isolation facility.
Are they being guarded or monitored?
Yes, they are being monitored. In fact, most of them will have some level of stationary monitoring just outside their facility. It's not always easy to maintain that, but I know that there is also random patrolling on all of those areas. There is a team that works 24 hours a day, just moving, I mean, in shifts, just moving between all those areas that they are under home isolation.
Dr. Fong, the issue about clusters, there was a lot of almost misinformation about, for example, when you talk about Navy cluster, people thought that all of those cases are just Navy officers. Monikoso cluster is just all cases from Monikoso. Can you explain about clusters? And I noticed that now you have moved to areas of concern so that people can understand.
Yes, we used the word clusters originally when we were able to figure out the change of transmission. So when we talked about the Navy clusters, we talked about the positive cases who are the naval officers, plus their contacts. So all their contacts were also included as part of the Navy cluster. And when it came to Monikoso, we were able to track somebody who moved in from Nandali, came down to Monikoso. We were able to track cases that he transmitted to, and that was easy for us to work out on Monikoso. As time went on, a place like Monikoso started springing up cases that were unrelated to the original case. So then it became difficult for us to say Monikoso cluster, because in actual fact, it represented 2 different clusters from a clinical point of view. So this is why we are trying to transition into the words areas of concern, you know, because if we keep on using the word cluster, technically that's for us, it's a wrong word to use. That has nothing to do with the transmission dynamics now. Areas of concern. So what we have done is I must admit that we are struggling a bit with verifying these areas of concern, because one of the problems with doing areas of concern is that if you get it wrong, you can create unnecessary panic, and everybody will be wondering, why do you say I got a case in my area when I know I don't have a case? So, and plus I do know that we rely a lot on the information that is filled in the form when they do the swab. Given the number of staff that have to turn down, some of the information on the swabs have been fairly limited. So now when we get all our results, like I had about 126 this morning, it's taken us quite a while to go back and forth to try and figure out which place these persons are actually being geographically located. So even up until now, from 8 o'clock this morning, we've gone back and forth. We ring one team, the team is out in the field. We have to wait for the team to come back before we talk to them again. So it's becoming a cumbersome and difficult journey to try and sort out this information in a timely manner. In fact, it's one of the reasons why our statement keeps coming out late, is because we have to wait for all the teams to come back, rest, with the team that come and rest, and then when they just feeling like having a rest, and then we're ringing them up again and badgering them to give us extra information about missing pieces that we have to work out in the cluster. And I must admit also that this is not the only job that we do. I mean, unfortunately, we don't have any professional comms people around who can write up our statements regularly. And we are all trying very hard to figure out a response. And the response takes up all of our mental space. The 3 of us, myself, Chemesa, and Alicia, we spend an inordinate amount of time, starting from about 8 o'clock in the morning until at least about half past 2, working out where is the next place to go to, what is the next thing to do. And then we have another 30 minutes to try and pull together a statement from scratch. And in the process of that, we're banking on trying to get those statements of those the areas of concern all organized. So, I mean, people might say, oh, how come your comms is so disorganized? I mean, really, if you go to other developed countries, their comms system is totally different. They have one group of people dedicated solely to pulling the statement together. And I mean, if people keep on saying that they want to compare us to New Zealand and Australia, well, sorry, people, this is Fiji. This is how it's been all this time. I know that we should have improved. We should have gotten better with time. But the fact of the matter, we don't have risk comms around. We don't have many people who are specially trained in risk communication. We just have people who are generally trained in communication. And so, for us, if we had medical risk communications people, it would have been easier for us to get our medical risk communication people to put the technical angle to all our statements and at least still make it sound easily understood.
And you don't only look at COVID response, you also have to look at all the other issues because you have to run the health ministry as well in totality.
Yes, I mean, we are actually, you know, I mean, we also trying to set up our non-COVID services. We're trying to mobilize resources for all our ICUs. And we're talking to we're also trying to deal with the fact that a lot of our teams have to keep standing down and we have to keep mobilizing new bubbles into the teams so that they can keep the service going. So there's a lot of areas that extend well beyond COVID that needs to be sorted out. Unfortunately for us, the communication part is beginning to take an inordinate amount of time.
Dr. Fong, people are also asking whether you will continue with the option to have targeted area lockdowns. How successful has this been? And do we expect more of this as more cases go or increase in many areas and it gets scattered in different parts of the country?
That's a good question. From what I could work out so far, we've been able to, using our targeted lockdown scheme, we've been able to, you've seen cases go up and come down in each of the areas, okay? When it costs now you're down to about like 1 cases or 2 cases, and these 1 or 2 cases are usually happening in places that we expect to find. There are people, especially those who are on day 14 of quarantine, they become positive on day 4 or day 12. So we're still finding a few of these cases now. There's a few of the other small locations that had many cases before. Whenever we apply a short lockdown protocol or a screening protocol around them, we are able to contain the diseases within those targeted areas. Yeah? We are also noticing that our numbers in Nandi, in the Nawajikuma and the Tremline Nawaka area also are beginning to decrease in terms of the number of cases we report per day. So does lockdown as a method work? It does work. We know that it works when you are able to ensure that there is adequate amount of stay-at-home measures that you use to supplement the lockdown. The provision of food, the provision of other amenities, all those things are happening at the moment. So all our lockdown areas, usually when we have a lockdown, somebody goes out and they have this special app where they fill in all the household numbers, household names and the telephone contacts, and they send it up to Ministry of Economy. And then the Ministry of Economy have another team that comes in and does all the distributions. So we, you know, from that angle, the lockdown does work in specific areas. But of course, whenever you get 1 case outside of a lockdown area, that means it's just things keep moving on. And that remains a challenge. That remains a challenge. When you're doing mitigation measures, In many instances, you're trying to just slow down the spread of the disease, make it stay within the areas that you define, like currently it's staying within the central division. Ensure that you got good protocols that relate to movement of people outside of your red zones, just to make sure that those protocols are effective enough so that if a person who moves outside of your red zone goes into a green zone, if they become positive, they are positive during a period of quarantine while they are under containment. Okay, so you keep up that one. That would reduce the risk of spread, and at the same time you keep escalating with your vaccination program.
Now, so just turning to vaccination, what will happen if people do not get vaccinated, do not follow the COVID guidelines, and the cases continue to spiral out of control?
Yeah, we've seen all the examples of what happens. We've seen examples overseas, America, UK. You've seen it you're seeing it currently in Brazil. They report about it in India. Whereas cases begin to spiral out of control, then more and more cases begin to require ICU care. Yeah? At the moment, as I said, we have 12 severe cases. They just require oxygen support, but none of them are requiring ventilator. We have none of our cases requiring ventilator at the moment. What's going to happen is if we continue, people start to reject vaccination. They keep rejecting the COVID-safe measures. That group of people will start to take up a lot of our health resources because the sick will come from them. As they take more and more of the health resources, we have less and less for the COVID, for the non-COVID people. So that means it begins to affect the person without COVID who requires diabetic services and other non-COVID duties services. We have set up, that's one of the reasons why we have made a clear separation in the central division between the COVID and the non-COVID services. It's one of the reasons why we needed the arena to be set up as a field hospital for non-COVID duties. And so far we've been working, and like I mentioned, as things progress, we have a contingency plan to extend the arena services into another place directly opposite. And we will be discussing a lot more with our colleagues from Australia and New Zealand who have been through the same type of scenario, who can give us some more, help us to formulate a lot more of our contingency plans.
So I know you've got powers under new laws that were passed in Parliament in relation to fines, etc. When will fines for not wearing masks, having social gatherings, etc., businesses not following COVID protocols be implemented, and have the fines been determined for people not following protocols?
I do know that there is, this is in the area of law enforcement. I only know that we do have spot fines that have been legislated. I do know that there's been a number of powers have been provided for us to apply legal punitive measures against those who do not wear masks and those who do not follow the COVID-safe protocols. I do know that most of the businesses who are wanting to operate, they do have to sign an undertaking that has clearly indicated that there is the legal implications of not complying by the COVID-safe measures, and they actually sign off on that. So I guess what you're asking about really is the foot police or the patrolling police who goes in and says, you're not wearing a mask, you are therefore arrested. The police will have their own procedures that relate to that, but they can do it at this moment.
With COVID already consuming so much of your time, you've already highlighted in relation to your frontline workers, health officials, on top of dealing with other health-related cases. What would happen if or when you start getting many COVID cases, many severe cases? What is part of your risk management or mitigation plan?
I mean, I've mentioned already in the past that, if you get to a maximum point where you're beginning to have a lot more difficulties in containing the disease, then the normal process or the normal plan or the normal recommendation that is coming with regards to all pandemics is that then you go into mitigating against death and severe outcomes. So that means that we'll have to pull back all our resources into the hospitals. It means that a lot of people will have to be working on the sick people while at the same time helping to navigate and contain the virus within special sections of the hospital so that they can continue functioning on the non-COVID part of the hospital. That's going to be in the most severe scenario, especially like when you find in most of these countries where they have a lot of deaths and severe disease. Then what they do is they pull back on the containment measures that's out in the community, and they throw all their energy into just dealing with the sick. And that's exactly the kind of, I mean, that's the only thing that will be available to us if things continue to progress.
Dr. Fong, how many ventilators do we have in the country? How many more are being ordered? You had said more have been ordered. And when are they coming? With the equipment, how many cases, severe cases, can you look after at one time?
Currently, in terms of our ICU capability, this is talking about severe cases, like you're talking about ventilator.
Yes.
Yes, ventilator. Ventilator alone, in the whole of Fiji at any point in time, usually we'll have around 20 cases, a maximum up to 20 cases on ventilator. But we have enough reserves to go up to 40 for ventilator capacity. And then once you get up to 20, then you start creating new ventilator spaces. So we do have a stock of about 20 ventilators again that's sitting in reserve. And I know that there's another thing called an airvo. It's a special ventilator-like machine, but it's not a ventilator. It helps to clear up the lungs and prevent you from requiring a ventilator. And that we have I think we have about 25 to 40 new ones that are sitting down. I'm just not sure of the numbers because I know that a few more had come in. So, but 20 to 40 new airvos are sitting around for us to use. We have access to others that we can pull in when we need it. And I mean, I think that given the current situation and the way it's escalating, we will at some point, if we continue escalating, we will outstrip our reserves if we allow things to continue to escalate. And this is one of the reasons why we badly need a lot more work in terms of maintaining COVID-safe behavior, trying to reduce the spread of the disease. I guess one of the most difficult part about this disease also is the fact that it not only affects our health, but it also affects our ability to generate enough economic base for us to mount a response. Because bills have to be paid. We need medicines, we have to pay for all that. Sure, we're getting donations, but not everything will be part of a donation. They'll still have to be paid for. And so there are those who have, we have had to pull a more middle line to try and make sure that we do have enough to sustain the response.
Now you've got FEMAT running, you've got a number of frontliners there at the field hospital that have been pulled in to do that, and they've got their own COVID measures going on. You have OSMAT coming in. How will that work with FEMAT in operation, looking after non-COVID as a non-COVID care facility, and OSMAT coming in? What kind of support do we expect?
So the initial team that's coming in is not a hospital. So basically, this is the lead team. And what the lead team needs to come and do is to look at the shape of any further hospital-like support. But even before we do that, we need to organize a few other things on the ground. That means we'll have to look at a lot of our current infection control protocols, a lot of our infection control protocols, our isolation protocols, and our quarantine protocols. In all countries of the world, as you've escalated with the increasing number of caseload, a lot of those protocols actually change. They don't go the way we run it right now. They undergo a lot of changes. In some cases, people who are sick and, well, who are test positive but are not sick, they can be regenerated into the workforce, but they'll work, in a safe space. But they'll still be able to supplement the workforce. So a lot of what they're doing is we're going to look on their experience in how we look at the new protocols as they operate in a highly mitigating in the advanced stage of a mitigation response. That'll be one of the big things that we are looking at.
Now, Dr. Fong, what would happen if we do not have herd immunity? Cases continue to rise. You've said, as you've always said, whenever a country has had more cases, then you have more severe cases popping up. You'll have more deaths coming up. With herd immunity, if we do not achieve it in the next few months or end of this year, what would happen?
Herd immunity is, of course, if you could never achieve herd immunity, then we'd be in a lot of trouble. That's obvious. But I think the
people would want to know what would happen.
Yeah. Basically, what will happen is that we will end up with a lot more severe outcomes from COVID-19 if we were not able to achieve it. If you look at places like UK, USA, and most of the other countries that have started vaccination, a lot of them have seen an impact on severe outcomes, even when you reach vaccination levels of 60, 70%. They've already seen a drop in their severe outcomes. Yeah. So ideally, herd immunity is usually around, you're talking about 80%. But even before that, a lot of countries have seen a lot of benefit just with 60%. So if the idea that we have to wait for herd immunity to get an impact, that's what I'm getting at. It's not true. You can get an impact even before you reach the levels of herd immunity. It just needs that we keep on immunizing as many people as possible.
Let's talk about Fiji's targeted numbers. We're sitting on about, the last check was about 43% of the target population vaccinated with the first doses. The head of vaccination task force, Dr. Rachel Devi, says, based on availability of doses, we could go up to September, October, we could have about 70 to 80% of the target population vaccinated. How does that look for you?
I think given the current schedule of what's supposed to be coming in, we are looking on target for that to happen. We have currently got about like 70,000 vaccines that are sitting around ready for deployment. The vaccination teams took a rest in the weekend. They start again today. We are giving about 10,000 vaccines to the north so that they can start vaccinating some of the people who are exposed to those who are returning, and especially those who will be looking after their quarantine facilities. We want to make sure that they are all vaccinated or immunized. So once we deploy the 70,000, we can finish 70,000 in close to a week or 2 weeks. We can actually get 70,000 into the arms in a very short period of time. We also know that Australia has made a commitment for a minimum of 40,000 vaccines per month. So that's also going to help us as they strive to get to their 1 million doses for Fiji. And we know that we are looking at New Zealand giving us a fair amount of vaccines by the middle of July or towards the end of July. So I'm optimistic that we will get the levels of vaccinations that we require for us to have an impact in preventing severe disease and death, or at least in preventing most of it, or minimizing the risk. When you say, will we achieve herd immunity? As I said, enough to get the impact that we need. That is to minimize the risk of severe death.
I think it's important to also highlight the concept of herd immunity. Some people were asking, how does herd immunity work? We want to hear it from a medical professional. How does the herd immunity, or as you work towards increasing the vaccination rate, work in reducing the risk or lowering the number of COVID cases?
In this instance, you've got two parts to the whole herd immunity discussion, and there are others within the health system that are able to give you a more technical explanation of it. But there are two parts to the herd immunity equation. One is the prevention from severe disease and death. That's one part. The second part is the fact that you reduce the risk of transmission. So the idea, therefore, is that if you got 80% of the people who are able to reduce their risk of transmitting it to the unimmunized group, and you got most of those people, 80% of the population are protected from the severe diseases, to a large extent, by increasing that amount, by having a critical mass of people immunized, you are also protecting those who are unimmunized. Yeah? And if the unimmunized happen to be the first one to get infected, then it comes to those who are immunized, they tend to be protected as well. But to a large extent, just the herd immunity bit extends to when you have a critical mass of people who have been vaccinated to the point that it is protecting even the unvaccinated, because you're reducing the risk of that transmission to them.
Dr. Fong, how is your vaccination team coping? You had some issues with some of the teams with active cases turning up at the vaccination centers. That is also a concern?
Yes, all the medical teams have been struggling with this, but as I said, one of the things that we will have to work hard on is infection prevention control measures, and that's how PPEs need to be escalated. In the past, what we were doing was we were using certain PPEs only when we were doing medical procedures. Face mask, N95, the full coverall. Those were actually supposed to be mostly for medical procedures. But increasingly now, because of the risk involved, we are now escalating a lot of PPEs to be used by even those people who are doing vaccination. And the main, of course, the difficulty is that every now and then they get a exposure, and then they have to turn down. And the problem is when you have less number of people working, then it takes a longer time. You have to pay more attention to your PPE requirements, and you have to try and finish more people. So it does put more pressure on those who are actually in the field working. But from the discussions, I can see that a lot of the vaccine group, and in fact the whole group, a lot of them share Bible verses every morning. They all speak words of inspiration to each other, and they're still motivated.
Now, what is your message to the undecided who are still unsure on whether they should get vaccinated? Some people are still confused. Some people are afraid, fearful. Why is it so important to get vaccinated?
I mean, as I said, a lot of us want to get back some semblance of normalcy. A lot of us want to be able to connect again with all our relatives. A lot of our social networks. Currently, we're feeling a little bit socially alone. I mean, one of the hardest things to do at this point in time is the amount of restrictions that I have to put on funerals. it's really hard. But those are the kind of things that we want to get back. We want to get our social connections back. Of course, we all want some economic gain from it, but I think the most important thing is that we all want our social connections back. We want to be able to sit with families and have that connection that we always have. Sit down, have our prayers meetings, and have our various go to church and attend to our spiritual lives in a way that close, at least as close as possible to the way that we are used to doing it. And we can do that if we vaccinate. That's the benefit of vaccinating. You give enough protection to the community for them to become socially connected. Without vaccination, it will be difficult. That journey to getting to being able to meet up safely with all your relatives will remain a difficult task.
Now, Dr. Fong, you've said about for some areas, like people do not want community isolation facilities set up. There's also, some people continue to call for strict lockdown. What do you want people to understand? What do you want people to do? Also, there's issues about people saying, this vaccination is not good, I will not take it. From your perspective, as the Permanent Secretary for Health, who is spearheading this and ensuring that we get out of what we're going through, you're saying there's escalating cases at this point in time. What do you want people to understand? And what do you want the people of Fiji to do?
I mean, the message is the same that we have said all along. But I think the most important message that we do need to send out, it's easy to just keep repeating the mantra, be COVID safe, wash your hand, mask up, and keep your physical distances, avoid crowds. Those are things that many of us can do. But there are those in the society that cannot do it. And we do need to look at how we're going to support people to be able to ensure they stay safe with the COVID safe measures. A lot of our businesses have now gone into having COVID safe measures at work. And in due course, it will require that they may have to start screening people a bit more avidly when they're talking about getting into work. There may be other protection measures that they'll have to pull into place that will cause people to have to have to take on COVID safe measures. They'll have to start they'll have to be careful in order for them to be able to engage safely with their workplace. So this is something that's going to move forward. We're going to move forward more strongly in the future. I hesitate to actually define all those areas because I do know that it can be a bit of a sensitive area, and I do know that those kind of restriction in terms of access to workplace and all those kind of things, they require some legal framework to work in, and therefore and I'm not qualified even to go into it. But personally, I'm just saying that my personal opinion is that we all know that we want people to behave a certain way. We want people to be vaccinated, yes. But moving on, there will have to be certain regulations on what kind of space you can engage in and what state or what is the minimum requirement for you to be able to engage in those spaces. I mean, currently you're looking at a lot of air travel is going to be restricted, or many of the airlines are moving towards restricting it only to vaccinated people. So, whilst I say that I do want people to maintain the COVID safe behavior and get vaccinated, I think the other part of the equation is that we need to ask ourselves, how can we support people to make good COVID safe decisions? That's a part of a bigger discussion. And to me, that kind of discussion requires the involvement of a lot of community-wide members. It has to be a broad section of the community that has to be able to sit down and negotiate this question, especially asking the relevant question for those who are less fortunate, those who live in crowded settlements and those who don't earn as much as others. We need to give them options for them to be able to be COVID safe. And those who have means need to be able to share those means with those who do not have the means in order to try and create a more COVID safe space for them and make it more easier for them to be COVID compliant.
From the health perspective, you really need people to get vaccinated out there when the centers are near their place. You're getting the vaccines closer to their homes.
There is a number of vaccines that we have another program that we are moving closer. One of the reasons we're moving vaccines closer to the homes is only because we're trying to avoid a lot of crowding. Initially, when we started, we were not that successful, but now I feel like we have gained a lot more control, moving in controlling crowding at vaccine sites. But the reason why we have multiple sites of vaccination now is because we want to move it closer to your home so that we can avoid, we have a lower risk of crowding. Ideally, otherwise, it would have been nicer if we still had the option of everybody coming to the arena and we finish, because when we have the arena, we were able to finish a huge amount of vaccines in a very short period of time. I mean, we were hitting rates of close to 15,000 a day when we were doing that. But, the situation is what it is. So we now have to start being a bit more selective about where we go and targeting certain groups of people, in which case then it means that our vaccination rate is a bit slow.
Question for you. How are you dealing with mental stress? You did touch on that, really stresses you out. Dr. Tundravu, Dr. Alicia, your frontliners right at the front every day, as you're saying, counting the hours, sometimes till late at night, early in the morning. Really stressful, challenging times, cases escalating. As the man in charge, you've been wearing a lot of criticism at the same time. Simple things like, why didn't the announcement come on time, maybe half an hour late or 45 minutes late? Can you tell the people what goes through your mind, knowing that you have to balance out everything, including you personally, to ensure that things are going in the right direction?
Yeah, I got a good family structure. It's very stable. My parents, they pray for me every day. And I think one of the good things is also I've got a good group of colleagues around this place. We support each other. We care for each other. And I think one of the part that I do understand, see, before I struggled to understand this, the criticism. But as time has gone by, I've realized, people are frightened. And we just have to weather the storm. I mean, I appreciate the fear. But if the fear induces us to be constructive, to be able to do things that are going to be, that are proactive and makes us want to, help others, then it's a good thing. It is a little bit frustrating when you see that the fear only induces anger in some people and they lash out with negative comments and promoting negative ideas. We all understand the fear, we all understand the apprehension, but at this point, this is a type of time where there's only one choice. The only choice we have is a move forward choice. We've got to be constructive in our movement and whatever slip-ups that happen along the way, we need to be able to look at it and say, next lesson learned, let's move on. Lesson learned, move on. And that has to be the way it works. So I take comfort in the fact that there is no other option. People criticize. I got no option. I can't dwell on the criticism. I've got to say, what can I learn from that criticism? Even no matter how negative it is, what can I get out of it? And then I push on. It is what it is, Vijay. This. Sorry, it's I try not to get emotional about this, but the thing is, I know where I am. And I understand the situation I'm in. But for me to capitulate to the negativity is not an option. So it's not going to be an option. It's not going to be an option for me. Yeah.
Dr. Fong, thank you very much for your time. Thank you. And also to all your team members, the frontliners, for going out every day to ensure that we all see the light at the end of the tunnel. We know that things are difficult at the moment for the whole of the nation. And we want to say that as a nation, I'm sure after watching this, they will stand with you and to ensure that we fight this together. Pinava Levu, have a great evening, and thanks for coming on Straight Talk.
Naka.